Okay, right. I think we should make a start now. So welcome everybody to this afternoon's meeting here at the Lantern Centre in Ilfracombe. First of all, I'm David Rogers. I'm the Vice Chair of Healthwatch Devon, and Healthwatch Devon, along with our colleagues in Plymouth and in Torbay, are chairing these meetings because we are independent of the process. We're not part of the clinical commissioning group or any of the trusts or any of the councils. And so we are in a position to, to make sure that it all happens as it should and in accordance with the legal aspects of engagement and consultation. Also, I'm a volunteer, so I'm not being paid to do this either. So a few housekeeping points to begin with. Firstly, some of you have already taken advantage of the refreshments which are on the table over in that corner of the hall. If anybody else would like a cup of tea or whatever at any time, then please just help yourself. Then the toilets are through the door in the middle of the hall over that side, both the gents and the ladies. There's no fire drill expected, so if there should happen to be a fire alarm, then please make use of either this door here, to my left, your right, that one in the far back corner of the hall, or indeed the one by which you came in just now, and the assembly area. Obviously, I hope none of this will be necessary, but if it is, the assembly area is a yard just sort of over that way. Okay, the purpose of this afternoon is to have a brief look at what's called the Sustainability and Transformation Plan, which many of you will have heard about, and we're going to hear a presentation about that and a short video about it shortly, and then a slightly more detailed look at what is called the Acute Services Review, and that's the main purpose of this series of meetings. They only started yesterday, so that was in Tiverton. This is the second one today, and then that set of meetings is carrying on throughout this week and next week and into the third week, and we'll hear rather more detail about that. After we've heard those two presentations, there'll be a question and answer session when you can put any questions or comments that you've got to the panel behind me. I'll introduce each of those when we come to their turn to speak, and then after half an hour or so of that, then there will be discussions around the tables at which you're sitting. Each table has got a facilitator who will make some notes and try to keep the discussion focused on the issues that we need to talk about, and also we'll be able to, well, if you've got further questions at that point, they might be answered by the facilitators. If they can't be, then we'll refer to our panel here at the front of the hall as well. So I think without any further introduction, we'll move straight on to Allison Diamond, who is going to make the first part of the presentation. That's the part about the Sustainability and Transformation Plan. Alison.
Hello, can everyone hear me? Gosh, that sounds really funny. Can everyone hear me now? Is that better? Welcome everybody. My name's Allison Diamond. I'm the Chief Executive of Northern Devon Healthcare Trust. And there are some familiar faces here today, and it's good to see people come to hear what is progress on the work that we are undertaking through the STP. I think it's really important for us to, first of all, refresh our memories on what is the Sustainability and Transformation Plan and why we are doing an Acute Services Review. To do that, and the reason to do that, is so that we can canvass your views, engage with you and get some feedback so that we can feed that into the process. We don't have the answers today. What we are describing to you is a journey that we are going on that started for the Acute Services Review back in November, December last year. And this is an update on that and to hear your views about some of the developments that we are taking forward. So, what is the Sustainability and Transformation Plan? It is work that is being undertaken by the whole of Devon. It is one of 44 across the country. And it is the plan that is designed to implement the 5-year forward view. What it will do is it will bring together in an integrated way all the needs of the population, and also try to address the challenges that we face in the identified acute services, which you will hear about later. So who are the STP? They are a collaboration of the organisations that either buy the services of the NHS, or they actually provide the services of the NHS. They are also the involving the councils, who are the responsible people for delivering the social care in Devon. There are 11 key players, and then there are many other contributors that we seek advice, guidance and engagement from, including Healthwatch, and also the 160 GPs that are present across the Devon area, Devon doctors who provide our out-of-hours service, etc. Case change video. So this is the rationale for why we need to make the changes in Devon.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care.
There are almost 400,000 local people, including 18,000 children, living with a chronic condition, and their needs are complex.
Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable.
We will be more than £550 million in the red by 2021 if nothing changes.
Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton, Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on health care for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget, but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high-quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Okay, that showed some of the challenges that we have as a system in Devon. And in terms of the plan, that has to be now coordinated into what are we going to do to address that. And this slide here identifies those things that were brought out in the video. Our prime raison d'etre is to improve the health and well-being of people in the area, and to do that we need to recognise that we have a growing population of older people. We also need to know that there are health inequalities that we need to address, so therefore there may be different challenges in different areas. The services have grown up incrementally over the years, so different patches have different services. It's really important that we look at the variation in those services to see how we can make sure that people can access the service they need in the area that they live in. And the best part of this, I guess, is making sure that by building that independence, we eliminate those people who are currently in a hospital bed and move them to the place that they should be, which is in their own homes. That is vitally important in terms of maintaining your health and well-being. All of that has to be provided within the financial envelope that we have. And it was recognised in the video that without making the changes that not only make our services fit for purpose for the future, we also have to address the fact that we are currently in a position where if we do nothing, we will be significantly in debt. Within the STP, there are 7 priorities that we are focusing on, and they pick up different parts of the video that you have just seen. So, if we are going to maintain people in the best independence with the best health and well-being, we really need to focus on prevention and early intervention to try and keep people as healthy as possible. If they do need our services, then they need to have services that are person-centred and integrated. We have tales now where people tell their stories very frequently. How do we eliminate that so that people are able to tell their story once and then the services are integrated around the care that they need? Moving on to service-specific areas. In primary care, we've just heard that 1 in 4 GPs are going to be retiring in the next 5 years. That means there is a whole piece of work that needs to be undertaken to see how we can look at our primary care. How do we make that more resilient going forward if we're going to have a reduced number of GPs? And what does that look like in the future? Mental health is nationally underfunded, and the poor relation. How is it that we are going to tackle that for Devon? We've already heard that 95,000 people have a chronic disease and a mental health condition. We do use resources on those people, but their outcomes aren't as good as they could be. The focus for today is on the Acute Services Review. That is targeting the key areas mentioned in the video of urgent care services, maternity, and paediatrics and neonatology, and stroke. And then finally, we have the last two areas. We cannot neglect our children and young families. They are the people who are, if we don't maintain their independence, their well-being and their health, are going to be healthcare users of the future. And the health service is funded by taxpayers' money. It is incumbent upon us to be as cost efficient as we can be with the resources that we have. I'm going to hand over now to Dr. Chris Bowman, who will take you through the Acute Services Review.
The microphone is being handed over. I remind you that after this next part of the presentation, there'll be an opportunity for questions and answers.
Okay. Hello, can you all hear me? Excellent, sorry. So I'm Dr. Chris Bowman. I'm Deputy Medical Director at North Devon Healthcare Trust, and I certainly can recognise some of the faces in the audience, so it's good to see you all here. As I say, the focus of today is around our acute services, and that's the acute services that are provided through the four main hospitals in this STP area. So that's North Devon, Royal Devon and Exeter, Torbay and Plymouth. I think it's important to remember that this actual STP process is providing us an opportunity to find ways of how better we as providers can work together to make the best of the limited resources that we have. And it's not just about the four acute hospitals. This is working with the ambulance service, because there's no point us having this discussion now as to how we deliver those acute services in hospitals if we've still got patients stuck in ambulances waiting for hours outside, recognizing that time is important. So we need to ensure that within this review, we get the flow of patients through our acute services as optimal as possible so that we benefit patients as best we can. And the challenges to that, and the challenges that the STP process has, is the fact that we are trying to deliver these services, recognizing that within the consultant workforce, there are approximately 12% vacancies nationally. So, and we have our fair share of vacancies here in this area. So it's not as though we have a full complement of workforce. I mentioned consultants, but that's true not only for the medical workforce, but it is also true for the nursing and therapists as well. So we're trying to provide the services with a limited workforce that we have. And that causes restrictions on what we can do. But by thinking wider and working collaboratively together, we can come up with network solutions that may help minimize the problems that those shortages cause us. We also have the challenge that we are expected to provide 7-day services, so that whatever day of the week you come into hospital, you can expect the same timeliness of intervention and review and management as you would on any other day. So, as Alison has outlined and as is stated in the video, there are 3 key main areas, and each of these areas the work stream for these 3 areas is being led by a medical director from one of the 3 trusts. The 4th medical director is Phil Hughes, who is the chair of the clinical cabinet, and has his own stack of duties he has to perform, so he's not leading one of these work streams. But as you can see, for the hospital urgent care, then we have Adrian Harris, who's the medical director from Exeter, who's leading on this. And as you'll see, And you will see these statements, and if you've read the pack, many of these statements are the same for each of the specialities. It's around staff shortages and the national requirements around 7-day working. It's the fact we are all struggling to meet the standards that we're required to meet as far as the quality of service that we provide, and especially you will know as far as A&E is concerned, meeting that 4-hour target and ensuring that we are seeing all patients within that 4-hour time zone. And for us in North Devon, then our medical director, George Thompson, is leading on the stroke work. And similarly, once again, we can say that there are not enough consultants or staff across the patch to deliver these services as the standards would dictate. Compounding that is also obviously the fact that we are an ageing population. People want to retire in the southwest, so the numbers of patients are increasing, so that similarly puts an extra pressure on the services. There's issues around identifying those patients, or patients realizing that they need to act promptly if they're to achieve the best outcome from the services that are available. I think many people will realize that certainly ideally if you're thought to have, or it's anticipated you've got a clot in your brain, that you need those clot treatments within 4 hours of you having had the stroke. So not only have you got to recognize that you've had a stroke, you've got to make the whole system work so that you get somewhere, so you get the treatment. And ideally, the sooner the better. And similarly, the evidence does support that having the right treatment and having the right teams to provide the physiotherapy, occupational health, and occupational therapy and everything else to support your recovery is similarly very important. But once again, there is a skills shortage across the patch and nationally, and it's how do you therefore ensure that that most people get the best treatment all the time. And of the trio, then the maternity paediatrics, that's been led by the medical director from Torbay, Rob Dyer. Same problems again around staff shortages. High use of agency staff. Agency staff are an issue. They're an issue for all of us. We're all trying to reduce our agency staff by as much as possible. They cost more. They don't provide the continuity of care that our regular staff would provide. And we are aware that you're more likely to have unwanted harm effects as a consequence of agency staff. So we're all working really hard to minimize that. But then that puts extra pressures on the remaining staff. So how do you maintain a viable service in those situations? And certainly we have, from a pregnant woman's point of view, a limitation on the choices they have as to how and where they deliver. And we would wish to address that as part and parcel of the process. And similarly, once again, it's not hard to understand that the problems that people can get pregnant at a later age through assisted pregnancies and so forth. So the challenges, the medical challenges that are associated with pregnancy are also increasing, which in itself puts an extra strain on the system. So, why are we engaging with you? I say this is, as Alison was describing, this is a process. There are work streams going ahead at this time looking at these 3 services and how it is felt they should be delivered in the future. What we're here to do today is review the criteria that have been suggested by which we determine what the options are and what will be the best fit going forward. And so In your packs, you will see there are some, I'll come on to them, some decision-making criteria that have been suggested through these work streams. And really the work for today is to consider each and every one of these. As you see, safety delivers improved patient safety. I think most of these are self-evident. Quality and outcomes, that do you want to be assured, do you think it's important that we are providing the most effective care that we can? Access, the ability for patients and carers to access the services, to visit relatives when they're inpatients, and also to ensure that they can access the services in a timely way when required. And sustainability, as I mentioned, we do have a problem with not having adequate staff to deliver all our services at the moment. So how can we encourage staff to stay? How can we improve recruitment? How can we ensure these services are sustainable going forward? Is that an important criteria that you feel we should be considering? Similarly, training. How does whatever option we come up with, how will that support training and future sort of provision by clinicians? And cost effectiveness. Obviously, working within the NHS, we're all public servants, and we all have to ensure that we're providing or work towards providing the best value for money. So how can we ensure that we are really getting the best value from the taxpayers' money? Patient choice. Similarly, how can we promote that and ensure there is choice? And finally, but not least, is user experience. How do we ensure that the services that we actually end up providing are certainly no worse, but hopefully better than they are now? Is that an important criteria too? So that's the range of criteria that we are proposing. You may have other ideas, and we would like to know if you have other ideas, other suggestions, whether you, through the sort of table discussions, whether you could raise those, mention those, and obviously we will be collecting those at the end. But really this is what today is all about, is actually looking at the criteria that will be used when we come to determining the options that are going to be considered. So it's very important that we have your say in what you feel is important in this process. Thank you.
Thank you, Alison, and thank you, Chris, for introducing the two parts of what we're talking about today. As has just been said, it's very important that you have your say or that you have your questions answered. So the next stage of this afternoon is a approximately 30-minute question and answer session to the panel. That's the two speakers that you've already heard from, and also Dr. John Womersley behind me, who many of you will know because he's a GP in this part of Devon. Just to remind you, you can ask general questions about the STP, which is the first part of the presentation, or you can start to talk about what these meetings are really about, which is specifically the Acute Services Review. That's urgent and emergency care in hospitals, it's stroke services, and it's maternity, pediatrics, and neonatology. Right, Oh yes, indeed. Some of you may have seen this large sheet on the tables, which is about recording your views and comments. The whole of this event is being recorded because that will help to check that whatever written comments are made are consistent with the things you've actually said during the afternoon. So if anybody has any objection to that, then please speak to the young man over there who just reminded me to say it, and he will make sure that that can be dealt with properly. Okay, so I'm going to walk around and take questions, one or two from each table, just to begin with, and we'll see how we get on with timing. So if you could indicate if you'd like to ask a question, and I will come and bring the microphone to you. Right, well, I'm going to start with this table because it's right next to me, but I've seen you as well, sir. Right, let's start right here, madam.
Hello, my name's Rosie Hayworth Booth. It occurs to me that the STPs across the country are working to arbitrary budgets which are set by government. And instead of doing this, wouldn't it be preferable to start from a position of need and work out what the costs will be for each STP and then apply to NHS England for funding rather than the other way around? And why is the CCG and the Healthcare Trust in Devon not networking with other STP areas across the country to challenge the budgets? And I would also like to know what percentage the £550 is, what percentage that is of the total budget. Thank you.
Who'd like to make a start with those questions?
Can you hear me? Is that okay? So I'll break down your questions into a number. First of all, there is a national capitation formula that is the way that health funding is allocated, and that is a weighted formula, so that means it takes into account That takes into account deprivation and other criteria like age, etc. And that is how our formula is worked out. In terms of that amount of money that we receive, it is incumbent upon us to use that money wisely, and therefore it is important that we review our services that we are currently delivering to ensure that they are the most effective for our service users and the most efficient in terms of the costs. I think the second part of your question was why we were not joining forces to challenge the way the allocation formula is undertaken and approach it from a bottom-up approach. Our responsibilities as a system and area is to deliver healthcare services within the resources that we are allocated through that national formula. I think it is important that we evidence, irrespective of how the funding streams occur, that we are using those funds wisely. There are various mechanisms that you yourselves are able to challenge those formula through your councils and MPs, etc., if that's an approach you want to take. But we are absolutely required to deliver our services within the capitation budget we have. You raise a very good point about should we be joining forces with other STPs to work together. Certainly there are services that we need to deliver across, for example, the peninsula, where we have highly technical services. They may be very complicated cancer operations, for example. For those services, to make sure that people get access to them, we would have to work with neighbouring STPs to ensure that we work together to deliver those services, because the catchment for those services would be much bigger. An example of that, for example, is the cancer services for children, which are delivered primarily by the Bristol area and enable our children to have access to that. They are rare conditions but very serious conditions, and it's important that we are able to access the expertise that we need.
Okay, thank you. I'm going to this lady here who I think was the first to have her hand up. So, madam.
Actually, this is the first kind of meeting I've been to of this kind. Just a few questions or thoughts. A while back, not so long ago, our local GP in Ilfracombe said that he struggled to recruit in this area. Is it a skills shortage? Do you have comments on that, please? Also, personal experiences with my husband, the speed for life-threatening conditions, in his 40s and his 60s, 20 minutes for a stroke or whatever has gone on, with other people, and also acute pancreatitis, heart, pneumonia in our personal family circumstances. deeply worrying. You're screaming down the phone. The paramedics are amazing. But then you've got to get to North Devon Hospital, and then beyond that, Exeter, and you know, the patient waking up in intensive care thinking, where am I? I know this is probably, you know, it's more personal, obviously, because it's happened in our family, but, you know, we don't want cutbacks, and whether we're here for cutbacks, I don't know, probably not, but it's the wider implications of all this that we're here now. And mental health, the lack of funding as well. Postnatal depression, how is that dealt with these days, for goodness sake? Thank you.
Okay, well, I don't know who's going to... Right, Dr. Womersley, thank you.
Yes, thank you. So this all started with the Case for Change, where we looked at services across all of Devon, and that was finished, that piece of work was finished, and we published that in February of last year. Part of that was the issue that you're alluding to, which is the number of GPs. And it's in GPs, and actually it's in the workforce generally. So the issues we're seeing now are, yes, partly about funding and money, because as a CCG, we've had to borrow money every year from the government. But more and more, I'm seeing the issue is around workforce. So in the GP services, in Plymouth, they are really struggling. So practices in Plymouth have been handing back their contracts to NHS England. In Northern Devon, we've been luckier in that we've been spared that situation, but it is now arising, I'm afraid. So I spent the last 2 years saying we're okay and we're safe, but actually we're not. So practices are having a lot of trouble. And there was a practice in North Devon, a good practice, that put out an advert across the country like we do in the British Medical Journal for a new partner. And they're a good practice. They didn't have a single applicant, not a single applicant. So there is a huge workforce crisis. And part of some of the questions are around, do we meet with other STPs? Yes, we do. So every month, I meet with NHS England and Cornwall STP, and the focus of that meeting is primary care and GP services. So if you haven't got a workforce to provide a service, you have to work differently. So we are looking at how we can use what we've got, the number of GPs we've got, to provide better services. So yes, there is a big issue around the workforce. As far as speed of services goes, then GPs are part of that speed of service. And we heard from Dr. Bowman there about stroke services, and the issue we've seen, because I've sat on the Acute Stroke Services review, as we saw on the screen there, we don't get people into hospital quick enough. It's not recognized. Now, there has been a big issue in the newspapers and on the TVs with this FAST business, F-A-S-T. There's no doubt if we can get our patients into hospital quicker, then we will have better results for those patients. Going back to workforce again, and if we concentrate on stroke maybe, the world is becoming much, much more complicated. If you take somebody who has a stroke and they need to have the clot removed, at the moment, that doesn't happen very often, maybe 1 in 10 or less. So actually that service is not available in Barnstaple or even available in Exeter. That's done at the moment in Plymouth by a very highly skilled clinician, and there aren't many of those in the country. So how we actually get around providing those sorts of services is quite difficult. So we are going to have to work very differently to how we use our money, how we use our workforce. And as Alison was alluding to, it's now, and quite rightly so, that we all get together as a single system and work out how we can use what we've got. So some patients might be treated locally, and some might need to go further afield. So again, when you talk about speed of services, at the moment, if you have a heart attack, and the ECG goes down to the main center in Exeter, and they say, do you know what you need? You need a stent, a little webbed channel to help open up your artery. You go straight down to Exeter. That is your best chance for that patient of survival. And it seems strange to go past one hospital to go to another. But actually, as the world's become more complicated, it's also about being in the right hospital, not just being in hospital. And that's a difficult concept, but we do know that's true for many services, and that's true to a degree of stroke as well. So we're having to think smart, and it is a different way of providing medical care. So that's all I've got to say. I don't know whether Alison or Chris have any other further questions. But.
Okay, well, we're not going to get around the table if all three of you answer the same one. I'm going to this table next, and then I will make my way around the room.
Thank you. I'm Peter James. I'm the chairman of the Combe Martin Parish Council. I also worked in the North Devon District Hospital in theatres for 15 years. My wife's a nurse who did the same. My daughter is a doctor. And I spent the last 8 years of my career working for the BMA. I just say that to say the questions and views I have are not alarmist. They are based in real experience. I want to focus in on the acute care. I want to focus in quite simply on the distance between North Devon District Hospital and Exeter and Plymouth. Since the SDP review started, just from not any detailed observation, there are only 2 roads that go down, decent roads, and they've been closed 11 times that I've noted. It may be more. You're not talking about an hour to get to Exeter. In some cases, particularly in summer, you're talking 2 hours or 3 hours with holiday traffic. And in all the 4 areas that you've focused in on the acute services, those sort of delays will lead to deaths amongst patients. That isn't alarmist, that's a simple statement of fact in my view. That's the immediate impact. Longer term, and we see it already with ENT services and other services that have moved to Exeter and Devon, to North Devon patients and their families, moving any of those services will mean enormous inconvenience. Very lengthy journeys, public transport is very poor or non-existent. To visit relatives in Exeter or Plymouth is extremely difficult and will cause enormous financial hardship as well as time hardship. And I think all those things are really self-evident. I've listened to arguments from professionals, I've been to many meetings. I don't think you can argue that will happen. And my question is, as health professionals, why aren't you saying those things to the government? Of course you have to rationalise. You always review services. Services constantly and continually improved whilst I've worked in them and whilst I've had experiences of them. The times that they get worse is when the finances get cut. It's underfunding is the root problem. We rely on you to say that.
Thank you.
Okay, so if I start off by talking about the distance, because that was the primary part of your question. First of all, it's important to recognise that when we are looking at all the services in the Acute Services Review, this is being looked at by the clinical teams in both, in all of the acute hospitals across Devon. Each of the acute hospitals were asked to put representatives forward for those 3 work streams, and the clinical commissioning groups put forward general practitioners into those 3 work streams. When we are looking at changes to services, we have to put the patient first, and we have to use the clinical teams to develop what are the services that will best meet those needs. Inherent in that are the distances to travel that are either time critical, and a number have been mentioned here, like stroke, like an urgent caesarean section, for example, and the clinicians who are sitting at the tables looking at the analysis of the data are absolutely mindful of that. We have people who are attending these meetings in quite large volumes from North Devon District Hospital. They are living and working in the area, and they are already transferring people who need to be transferred on because their urgent need is to be in the centre of excellence. So therefore, any discussions that they have are absolutely mindful of the distances. You mentioned about if this was to change, you know, there are also implications for family too. There are no decisions at this moment about what the models look like. What we have identified are the challenges that are facing each of those three areas, and then the clinical teams are looking at what are the solutions to those challenges, and we're here today to listen to, if we get through to what changing the services, how do we measure those to be the right services for people going forward? I think the second part of that question that you asked was around the funding, but I'm going to lose track on what it was. Did someone else pick it up?
Yes, I think the question was why are we not lobbying government, I think, effectively. So there's two parts to that. The short answer is yes, we do. Our accountable officer, the chief executive, you want, of the CCG, does meet with that level of government minister on a regular basis. Also, the leader of the STP also meets with the government on a regular basis. And what do they talk about? They talk about the fact that we haven't got enough money, that every year, so I've been part of the CCG, this is almost the end of my 4th year, we have had to borrow money. So they do know that we have not been able to provide services within our allocated budget. So that's half the answer. The other half is actually, I still think as a clinician we could do better with the money we have. So that's not a cop-out, it's just a recognition that part of our responsibility is to try and do things better. So we haven't provided services within the budget they've given us. They know that, and every year we've had to ask, we have to go back and ask again. So they're well aware, and their kickback is, we hear what you're saying, but also they think we could do better, and I think that is true. So I don't know whether that answers your question, but those issues are raised on a regular basis with ministers at a high level.
Okay, can I just remind everybody that we're at least halfway through the question session and we've only had 3 so far. So could you ask a question that is as specific as possible, and could I ask the panelists to answer as well, briefly as possible, but obviously covering the points that have been raised. Is there anybody from these rear tables that wants to ask a question? And we'll come back in this direction as well.
Thank you, I'm David Woodbury. We live in a dangerous world. Apparently I've lost 15 years of my life just by being here this afternoon. My question is about contingency planning. If you dismantle or reduce expertise from the North Devon Hospital, how will you deal with the issue of either Plymouth or Exeter not being available due to either a major nuclear incident, adverse weather? The assumption seemed to be that we can get to these other locations. Well, my memory is very clear, and I can remember the 1960 snowstorms, and I can remember travelling through 8 foot of snowdrift to get to Dorchester Hospital. So, well, what I'd like to have some reassurance is that there is some sort of contingency planning, which also takes into account the failure of local support services to get to the clients that you've pushed back to their best bed.
Thank you for that question. Each provider does have a business continuity plan already in place to address the issues that you're raising as far as inclement weather, snow, blocked roads and all the rest of it. So we already have planning in place to address that. I would suggest that actually if we're looking at an STP footprint, the fact that we can network, sorry, I'm being told to hold the mic closer. The fact that we can network, I think, and have network arrangements to support patients, I think actually provides an extra level of resilience in that service and in the way we manage patients. So that, shall we say, as a system, you're not necessarily, if we're all sort of working to sort of the common aim as to where patients should be, where is the best place, that you can make sure that you've set up the services to work to ensure that patients get there, so that we can review our business continuity plans to make sure patients get where they need to be. And if you're talking about nuclear attacks, then yes, one would have a plan that would cover the whole patch, that would address that. But that's what we do anyway.
Okay, gentleman here.
Thank you. My question is, why should we accept a worse service? In other words, cuts, and sign up to your whole concept? The problems that you outline are all a failure of management. For example, too much agency staff you mentioned. A third of the people don't need to be in hospital. Difficulty recruiting. People retiring. These are problems of management. Now, they might very well be problems that you can't solve because you haven't got enough money, and you ought to be shouting that you haven't enough money. Other points you might think, what about waste? There's been nothing on there about criteria about cutting salaries. I'm not talking about frontline staff, but administrative staff, like your own salaries. Particularly, Alison, when under your guidance, we've lost Bideford Community Hospital, Ilfracombe Community Hospital, and now Holsworthy Community Hospital, even though we were told by George Thompson, Deputy Medical Director, last week, that there were no plans to make cuts. A second area, what about equipment? It's never returned. That's an area that Lee's looking at. And I couldn't believe, when I was reading your report, the fact you didn't do bulk buying. When I was in education, all the stuff was bought, or in Lancashire, all the stuff was bought by the whole county. So they got bulk buying, and you're buying all your stuff from the local shop. Another area you can improve and save money is learning from your mistakes. Do things once and do it well. Now, in Torrington, there were 17 patient stories we submitted to you through the proper channels, and these have never been investigated. So you're never going to learn from your mistakes and improve your service unless you look at that.
There were quite a lot of questions there. Let me first start off by saying the first things that you raised were all are related to how we deliver our services and whether we can work in a different way to deliver those rather than change the services. I will draw attention to the presentation. Our services have grown up incrementally over a long period of time, and what that takes into account is that services change. The NHS has innovation that comes through all the time. This is our opportunity through the Acute Services Review to take a step back and look at what the best practice is for those services, and to look at the challenges we face in our current system to improve those services for patients. In that, we will address some of those thorny issues that you make reference to in terms of agency, vacancies in staffing, etc. And this provides us with a real opportunity to get things right for Devon. You move on then to talk about productivity, which is how we make best use of our resources. All of the trusts in Devon have various mechanisms that they bulk buy. The STP provides us with an opportunity to work in a much broader network so that the volume of stuff that we have to purchase, which is essential to maintain the services for patients, is even greater. So I agree with you absolutely. We need to look at the ways that we can look at that on a Devon-wide basis and in fact take up the advantages of some of the national work being undertaken to provide us with some of the essential things that are needed on the day-to-day basis for patient care. I think one of the other parts of your question was around the equipment that gets loaned out to patients. It is a complicated arena, the use of equipment by patients, but some of that is delivered by prescription to the patient, and other areas it is provided on a loan basis. Either which way, there are mechanisms in place that the service provider of the equipment collects those equipment so that it can be recycled and reused. It is very complicated and it is different in different areas, but they are not left to waste. We have had quite a number of letters about Zimmer frames, etc., and crutches being at recycling centres. Actually, that is one of the places that people can deposit their things so that the company can collect them for recycling. And I think it's important that you must be aware of that. I think that just about answered most of the questions.
I made the point earlier that if you ask a specific question, you're likely to get a better answer from the panel. So could I ask our final 3 questioners to do that if they possibly can? There's a lady here, gentleman over there, and a lady there. And then we'll have to move on to the next stage.
Can I just ask, with regards recruitment and retention of staff, I think particularly, say, in the large cities, moving out to the West Country is perhaps considered to be a bit of a backwater. I don't think that's the reality of the situation, but having spoken to some, particularly nursing staff, I wondered what thoughts you had on the recruitment and retention of staff in terms of attractive packages for people to come, both financial and any other incentives that you can think of, to make this appear more, I use the word sexy, rather than the big London hospitals or the big Bristol hospital or whatever, and also staff training. I know it's difficult because most training is held in Exeter or Plymouth, especially for nursing and other healthcare professionals, so it has a cost implication. But I think another aspect of perhaps people not necessarily wanting to come away from the big cities to this beautiful area is that they perceive there is no opportunity to advance their careers and their knowledge base. And I just wondered what thoughts, because it does come on your training, suggested clinical decision-making criteria, what thoughts or ideas you had on those areas?
That's an excellent question, and there are many initiatives that are already underway, and there is a whole enabling workforce piece of work happening across Devon. If I can just cite some of the examples of things that we can do. First of all, it is important to recognise that most of the staff in the NHS are on a national pay scale with very limited ability to flex that. Having said that, it is important that we work across Devon to look at what those flexibilities are and use them wisely and consistently so that we don't end up with one area stealing from another area and not solving the problem, just shifting the people. So there is work underway to look at how we use that in a more exciting way.
West is being paid, and you look at the grade that a London hospital ward system is being paid, there is quite a disparity. So I wonder if that's something that should be looked at if you want to attract good quality staff. And I know it's not just about money, but if you look at the large cities.
So the national pay scale is based on job descriptions. So therefore, when the job description is written, irrespective of the person in it, it is then scored against a scale by an independent panel, which gives you your answer. And that is the nationally adopted way of doing things. I think in terms of encouraging people to the Devon area, and North Devon particularly in view of where we are today. It is really important for us to look at the training and education and the career progression, and we have links, as do the other areas in Devon, with the universities. So the universities of both Exeter and Plymouth are developing their portfolio of training that they can undertake. We have worked in North Devon to look at how, when people who are resident in North Devon who are doing nurse training, to prevent them from having to travel long distances, can they do all their clinical work in one area around the North Devon area, but then attend the training for their theory on a much more intermittent basis to cut down the amount of travel and the impact on families. We also have worked extremely hard across the Devon area to look at how we share that training. Not all training has to be face-to-face. We can look at technology to see how that can improve the access to training. Some of that can be done through e-learning, but there needs to be personal contact too. Personal contact may not be on a one-to-one in a room together. You could have a webinar or something where you can see people. All those things are being explored by the STP because all of those 3 work streams had problems with staffing in various guises, and actually it's the key to unlocking the sustainability of the services going forward.
Hello, Alison. You remember yesterday I said to you at the Cedars Inn in Barnstaple, I thought that the primary objective of the STP is to privatise by stealth large parts of the NHS, which could be lucrative to private healthcare companies in North Devon. And to that end, how much, this is the question, how much has been paid to management consultants Carnell Farrer, and particularly Dame Ruth Carnell, to produce the case that the STP is using to either close or relocate acute services in Devon? And I can't help noticing there's a private healthcare bag there, the Nuffield Trust.
Just before that's answered, if it can be answered, the Nuffield Trust bag is mine, and it was presented to me given to me at a conference I went to.
So in terms of the support that the STP gets, I think I need to take us back in history a bit. Before the inceptions of STPs in April of this year, the new Devon CCG footprint, so excluding the South Devon part of Devon, was designated as a success regime area, one of 3 areas in the country. Those areas received funding which was not part of the capitated budget for patient and healthcare. It was additional funding to support those areas to develop a plan to get back into a sustainable situation going forward, not only in terms of finances, but also in terms of the services. It is that funding that has been used to do the analysis of the case for change, which you heard in the video earlier, and there are some compelling reasons why we really need to address some of the services that we have to improve the care for patients. My understanding is that there is no additional funding for STPs. STPs are providing the plan going forward to work in collaboration across a footprint defined by the, in our case, the area of Devon, and that is for the people of the teams in Devon to work collectively together on the premise that if you work collectively together, you get a greater sum of the part than the sum of the parts, and a better, more coordinated and sustainable service going forward. I haven't asked it directly because I'm not entirely sure of the sum. It is available, and it has been.
Right, well, I'm not sure we're going to get any further with that particular point, so I'm now going to take the final question from the lady in front of me.
Hello. To me, patient safety and access are absolutely intertwined in North Devon. And if we don't have acute services here, we don't have patient choice. And I'll give you an example of that. On Thursday, I was in Woolacombe and I met a friend, and she had a very pregnant lady with her. And I met that friend again this morning. On Thursday night, that lady went into labour. She had wanted a home birth, but it became apparent very quickly that something was wrong. She was rushed to North Devon District Hospital, reached there within 20 minutes. She had a placental abruption, and both her and the baby survived. So my question is, what would have been the outcome for that lady if North Devon District Hospital maternity services were closed?
I think, and that's why we're here today, isn't it? I mean, that's part of the criteria. Sorry. I hope it's with micro. Oh, there we go. Yeah, I got it now. And that's really why we're here today, is looking at the criteria which we feel are important. And no one's going to disagree with you that could have ended up as a tragic story. But as I say, no decision has been made about what the options will be, where services will be delivered. Today is about looking at the criteria and agreeing or getting your feedback as to what you feel is important. And I'm sure all of us on this side would agree that safety and quality are very important. But there are other issues here as well, and it's really taking the whole and getting your views on all of those criteria, and are there any other criteria that we have not raised that you feel are important and should be included? So that is the focus for today. But I recognise the story, and that would, if there are not alternatives that would manage that in a different way, then the outcome would not be good. But what we're looking at is, how do we make the best use of the limited resources that we do have? How do we ensure that patients do get the most effective treatments? I used to do a lot of work related to cancer services, and as you all know, we have tertiary centres for delivery of cancer services. We have those because it was recognised, if you put the expertise, well, we haven't got the expertise to spread out in every hospital across the patch, so you have to centralise expertise around different specialities to ensure you get the best outcomes, because I don't think anyone's going to argue that they wouldn't personally prefer to have the best outcome and travel further to get the best outcome. But what you have to ensure is that you're not causing a deficiency and patients to suffer as a consequence.
Okay, we've already overrun that session by 10 minutes, so we must move on now. If there are any questions, Madam, I've already allowed more time than was allocated for the questions. So I think that we need to move to the table discussions now, and if there are any unanswered questions, then those can be asked on the table. They will be recorded, they will be fed into the process, and if you look at the form that I can see you have in front of you, there is the opportunity to submit further questions directly as well and to get answers. So, no, Madam. Look, no, I think... Yeah, yes, I'm sure you would. I'm sure there's other people who would as well. But I think we need to have a period of discussion around the table so that everybody, not just those with the loudest voices, can have the opportunity to express their views and feed into the process. So the table discussions, I've already explained, sir, that anybody can ask a question on the table, and I said at the beginning that if it can't be answered around the table, then it can be referred to the panel. So we need to move on to the table discussions, which firstly is about the first aspect of the presentation right back over an hour ago, the Sustainability and Transformation Plan, and then the second part about the specifics for this afternoon, the Acute and Specialist Services Review. So as I mentioned, there are facilitators on each table. Could I ask the facilitators to put their hands up now so that people around the table know who they are? Okay, and over to you for this next stage. And then if you feel that you've had enough time doing that over the next half an hour, we will come back and have some more questions right at the end. Let's get in as many as we can in the last 10 or maybe 15 minutes. As I said previously, if you can make your question concise and brief and about a specific point, then you're likely to get a better answer from the panel. So please bear that in mind. Who would like to ask any further questions?
Can Alison please say why staff shortages are occurring with nurses, when I know, because I still have colleagues in the hospital who have told me that they are now being stopped from doing extra shifts unless they do it via the bank, which means it becomes a second job and they get taxed on that differently as an emergency pay. And I know this has happened in the last year, so it's not surprising we're having staff shortages.
There are a number of ways we have to address staff shortages, and we do look to our staff to work and do overtime. But you're right, we are setting up a bank. It is really important that we have local... We are currently setting up a bank that is designed to provide us with the local nurses rather than going to agency. There has been...
I worked for the bank and it existed, at least that I know of, until April last year.
So I would like to just have some facts on that. There was a bank in North Devon, you're absolutely right. We then moved our services to NHS Professional Services to provide us with our staffing at a reduced rate to the agency rate. We did some work with them through last year to see what their fill rate was for the free shifts that we had, and we have worked with them, and we are now creating a local bank once more so that we can fill in those shifts.
I'm not sure if everybody heard that. The question was, why is extra tax being charged because it's a second job rather than an additional shift with the first job?
Anyone who is employed on a employment contract has to pay tax once they reach the limits. I'm afraid that's just national tax rules. I don't think there are anything different in terms of the number of jobs that you have. It is the amount of income that you earn.
Okay. Yeah, I think the details will have to be dealt with in that way, and we might even need an answer from HMRC rather than from the North Devon Healthcare Trust. Right, who else would like to ask a question? You had one earlier, but I will take you if there's no other bidders. Anyone else? No? Right, okay. Your turn, madam.
Hello again. A large part of this sustainability and transformation plan is about people taking responsibility for their own health and about prevention. In Ilfracombe, we don't seem to have that groundwork being put down before you're planning to make these proposals. We failed to get the hub here. We have huge health inequality in Ilfracombe, and yet there are not the services to meet the needs of the people here. So I just wonder what is in the pipeline for places like Ilfracombe where you're going to be investing in services that would have been at the hub, such as healthy eating, smoking prevention. And I'll just give you one example of how this isn't happening. Last year, in 2016, I was sent a letter saying you're eligible for a free health check with your GP. I didn't get round to doing it, and then when I had to go for something else in January, I said, oh, can I sign up for my free health check? We don't do those anymore. The CCG got rid of that. And that is a vital where you'd be spotting diabetes, heart disease, cholesterol. It just doesn't make any sense when you're saying that prevention is such a big part of this sustainability and transformation plan.
So I think that having a focus on disease prevention and health promotion is really important. The STP is a 5-year plan, and there's no doubt that there's different services available to different levels all over Devon. Part of the Your Future Care consultation we've had in the last sort of couple of months and the proposals around how we might do things differently is exactly about having those sorts of services available. So we do need to have an integrated system in the community between GPs, nurses, mental health workers, all that sort of thing, and also spend more and more time around health promotion, disease prevention. And the health promotion side of things, part of that is Public Health England. So they have smoking clinics, and we have smoking clinics as well in the surgery. So there's sometimes 2 people doing the same thing, which is not a bad thing. I can't answer specifically about the health check, but if you came and asked me to have your blood pressure checked and that sort of thing, I can't understand why I wouldn't just do it there and then. But we do need to spend more time and more money on trying to help people avoid becoming ill in the future. And that will give them better quality of life. So I agree, it's something we haven't done well in the past as an NHS, and we will certainly be looking at how we do that better in the future. And that's why it's a major part of the STP. So we could do better with that, I agree with you.
I'm just going to take advantage of my position and add to that, even though I'm not really supposed to as the independent chair. There is the crossover in the elements of the question you asked with the public health responsibilities of local government, and neither the County Council nor obviously Plymouth or Torbay are represented here today, but they are part of the overall STP process, and therefore as this is being recorded, I personally feel that those aspects of your question should be answered by the relevant people in public health departments, as well as what you've heard from Dr. Womersley. So I hope the recording will show that. Right,
Madam. You talk of national standards being applied within STPs, things that you have to take into consideration. How definitive are these, that you have to stick to them? What do they mean? What you don't mention is the national delivery elements of the National Health Service, which we have lost in recent years, the universality and comprehensive coverage of our service. It used to be that wherever you were in the country, you could expect the same standard of care, or the same solutions being offered of treatments. With the STP, it would appear that we are going back to 1948, where we had local authorities running their own area with a very inward-looking health service to that particular area, with no guarantee that you'd get the same service anywhere else in the country. The whole point of the National Health Service was it was universal, comprehensive, publicly provided and funded. Publicly funded because and provided because that was the cheapest, most efficient way of managing your money. And now we have a system which is built upon lots and lots of different quangos, organisations which cost us a lot of money. The internal market, for example, being conservatively estimated at 4.5 billion.
So how can you justify the sustainability and transformation plan, which appears to be a form of sticking plaster, to put together all of the little bits that we've ended up with, these odd groups all around the country, in little footprints, each footprint doing its own thing?
Is that? I think the key point, I would just challenge your initial summary that there was equality of service provision from 1948. I don't believe that. I think there was a massive postcode lottery. I think there was massive inequalities in the care provided. You only have to look at CQC inspection results of now to know that those things have not been addressed and that there are failing practices. Sorry, failing. Bloody right next to my bloody. Sorry, but there are still significant number of failing practices, particularly in the London area. This is despite the systems that have been put in place to try and address those inequalities. So in general practice, we have the QOF, the Quality and Outcome Framework, which has been in place, 10, 15 years. These are things that have been put in place to try and provide a consistency in the outcomes for patients. We didn't have those before. We could all do our own thing. We could all do what we thought was best without an evidence base to support it. So I do not recognize the NHS that you paint of 1948 through to 1997.
Could I just add one bit? The first part of your question, Nettie, was around the adherence to quality standards. In the health service, when we look at reviewing a service to seek improvement, we also always start from what is the best practice that we can find in the area, and a lot of that is guidance that comes out from the Royal Colleges and other bodies that provide us with that information. Some of those are around quality standards for patient outcomes so that people get the service they deserve. Others of them are around how you structure that service to get the quality outcomes. That has to be the starting point for any of the services that we need to transform. I think then there is a but. And that but is that then right for Devon? And that is the work that has been carried out in the clinical work streams to date. They have to start from what's best, and there is an acknowledgement that some of the more structural bests are for urban areas. And there is no way that you can describe Devon as an urban area. So that is when you have to look at what is right for Devon. And people in this room have mentioned about the distances to travel, etc. So in answer to your question, it would be foolhardy not to start from best practice, but we then have to apply what is right for the demography and the environment that we live in Devon.
Okay, right. I haven't seen anybody else indicating they want to ask a question, so this really is your last call. Not another one from the people who've already asked ones. I don't think... Did you? Right. This will be the final one.
My concern has always been about the community hospitals, and we've cut down here. We had... all the consultation time last time, and we were told we were going to end up with 2, which was South Molton and Holsworthy. Holsworthy is now closed, or is about to close, take the beds away from there. And we've lost 4 in South Devon, we've lost some in East Devon. Devon County Council overspent their budget for social care last year by 5 million. We were lucky in Ilfracombe and North Devon, very good person here who looked after us, and we had a very good joined up service. What's happening now is that the budget is going to be spent over a whole district now because we've lost a lot of community hospitals.
are we still going to get the same joined-up service that we have in Ilfracombe when all the other areas are going to require the same and the money isn't there?
Thank you. I think it's a really good question that you ask. First of all, I need to clarify one point. There is going to be a temporary closure of the Holsworthy inpatients. That is not a closure of the hospital. This is because we have difficulties with staffing the hospital, and actually a difficulty in filling the number of beds there. We will be working closely with the CCG going forward to see what needs to be done as the next steps. So that's that point. You raise a very good point about the synergies between health and social care, but I guess I would put a counter argument to you. For many of our patients who are residing in community hospital beds, they have often had a stay in hospital in the acute section first, and then they are transferred to the community hospital for a further stay. For the stay in the acute, and I'm making a reasonable guess that it would be around 5 days, they will then transfer to a community hospital and stay between 21 and 28 days. It is well recognised nationally that the longer that you stay in a hospital bed, your muscle function deteriorates and your chances of getting back to a fulfilled, independent life is much less. We also know that there was a further audit of the people not only in our community hospital beds but in our acute hospital beds too last November, when we were looking at rehabilitation services for the trauma network. And at that point in time, there are still 40% of people in a bed, whether that be an acute bed or a community hospital bed, who could be treated in a different way. Add that to the evidence that is nationally available, that people actually recover better in their own homes if you can provide them with the services on the immediate discharge from hospital. So all our focus is around how do we transform our services to a much more responsive service for the patient, that as it does in Ilfracombe, and you thanked Chris for her hard work, actually wraps care around the patient that is in the locality so that they can recover appropriately in their own home.
Okay, James, could we have the last slide, please, the feedback one? That's it. Okay, so up there on the screen you can see what the next steps are. All the responses that you've made and have been recorded by the facilitators, or if you've written them yourselves on the various forms that were on the tables, they'll all be collated and will be presented to the STP Clinical Cabinet. The doctors, clinicians, they will then be using that feedback to inform the plans, and also they will have heard from the workshops, because there have also been some workshops about these various aspects of the acute services review. And then beyond that, that will feed into the next stages of the process. I certainly heard some discussion when people came and put questions to the panel an hour ago about the fact that there aren't any options on the table at the moment. Those are the ones that will be developed for the future, and that if there are any significant changes in the way current services are delivered, they will be further consulted on. So I know that sounds like a long-winded process, but that's the way ultimately, legally, it has to be done. So if you are still interested, I hope you've recorded your details on one of those forms if you've asked for more information, or if you've had a question this afternoon that hasn't been answered. And also on the tables, there's a list of all the other meetings in this series of engagement events about the Acute Services Review. So if you feel you haven't had enough this afternoon and you feel like travelling to one of those other ones, then those are the details of where they are and in which locations. All it remains for me to do then is to thank the panel Angela, Chris and John, thank you very much indeed for answering the questions to the best of your, Alison, Chris and John, to the best of your ability. And of course to thank you all very much for coming and sharing your views this afternoon. I should thank the facilitators as well, who've I'm sure have done the best they're possibly able to do to record the comments that were made around the table. So have a safe journey home, whether that's here in Ilfracombe or further afield. Thank you very much.